Shep, we have a question.
If you'll indulge me for about 30 seconds, it's like the dean at one of the medical schools I worked at said, Hurwitz, when you're young, you study history. When you're old, you are history. And as such, I got a little perspective. And for Ross, the calcaneal fractures, I trained at one of these illustrious residencies that had a guy named Harrison on the faculty who died before I got there, but he wrote the book Trauma, which was the textbook before Rockwood and Green on the subject, also a Canadian, by the way. And he was quoted as saying, trying to fix a calcaneal fracture is like nailing a custard pie to the wall. You can't do it. So the treatment was non-operative until they hurt so much you had to do something, except if there was medial lateral splay, you use this medieval torture device called the Boiler clamp, and you had this big C-clamp and you cranked on him under anesthesia and tried to narrow the foot. And then if it didn't work, you did some kind of operation. And then I met a guy named Joe Godfrey, who
Shep, your history. Come on, man.
Oh, I'm talking quickly. I'm an Easterner now, you know. So just Joe Godfrey's the last. He was a pioneer in sports medicine. I met him at the Naval Hospital in Bethesda when I was running a foot clinic. And he told me that when he was in the Navy in the 40s, you had to fix them because sailors couldn't get into a shoe. They impinged on the malleoli. So you had to do something to get the length back. Anyhow, there's a lot of history here. It wasn't always an operative indication, no how, no way, and some rather bizarre treatments have preceded us.
Tim, do you have a question?
Just two quick ones. Big fan of subtalar joint fusions. Do they do better if you try to fix them and then do a subtalar, or the ones that you don't fix and then do a subtalar? Is there a difference in the outcomes? And then for PRISM, is age a factor? I had a posterior malleolar fracture off my bike, and one of my younger partners told me I was too old to fix it.
That's not true. I'll answer that one. That's not true.
Mine works pretty good. So
Yeah. I think if you have the choice of if you can fix them where the soft tissue allows it, then I think an open internal fixation and then the fusion does the best because you maintain the height better and the width better. So I think you get a better scalces to do that. But a lot of times, in all fairness, you end up waiting for the blisters to go away. They don't go away soon enough to do anything, and you just wait it out. You do a subtalar fusion. But if you have the choice and you can operate in the patient, I think you're doing them a favor by fixing them. And then if they go on to develop subtalar joint arthritis, then you get a better foot to do that, and they do better with that. So just like the original, even when I do the Saunders 4, I do a complete open external fixation of the Saunders 4 and then fuse it. So you got a nice reduction.
All right, 2 quick points. Yes or no? Does everybody get a CT with an ankle and a foot injury?
Yes, for me.
As part of the imaging?
Absolutely, yeah.
I never say always, but for the most part, yes. If there's a posterior mal fracture, I don't do it for a routine bimal ankle fracture.
But for foot injuries, like you mentioned, CT for everybody. And then the last question for Dave. How urgent is it for the X-Fix to be on for a Pilon? How long do you have to get the talus out to length?
That's a good question. I mean, I think a lot of times the urgency is because there's, if there's, you know, skin that's at risk or something like that, that's obviously an urgency. Otherwise, I think these are cases that ideally are getting done within 24, 48 hours, but if it had to be longer for some
So a guy in the
reason,
community is going to send it to you, you'd rather have the frame on within 48 hours?
Yeah, I think that's a reasonable recommendation.
Fair enough. Okay, I think we're done. We got.
Shall I answer Dr. Bray's question very quickly? So I'm less ageist. So I think that if you have those signs of instability, incongruity, or an articular fragment that's incarcerated that's causing either of those two things, I don't think age is really the determining factor. I think we're really understanding it's morphology and instability that's the important bit.
There's hope for us. Okay. All right, great. Thanks, guys. We're going to end up and go to the next session.